Next is Dr. Mike Hogan, the former commissioner of the New York Department of Mental Health. Dr. Hogan is going to focus around the issue of physical health and behavioral health integration. Dr. Hogan serves as an advisor and consultant to behavioral health and health programs and systems. He's managed 3 state mental health systems in Connecticut, Ohio, and New York, in a career spanning from 1987 to 2012. Dr. Hogan also chaired the President's New Freedom Commission on Mental Health between 2002 and 2003, and was appointed as the first behavioral health representative on the board of the Joint Commission in 2007. So welcome, Dr. Hogan, and we look forward to hearing from your remarks.
Thanks, Tricia. It's good to be back. My career in mental health started under then Secretary Phil Johnston, longer ago than either of us would want to acknowledge, but it's good to be here. I am, as Tricia said, not going to try to sell you anything that New York is doing as the solution to challenges in Massachusetts, so I just want to make that crystal clear at the outset. But to really speak on behalf of what Dr. Harris has said about the imperative of trying to figure out how to do basic mental health care, and I underline that point, basic mental health care in primary care for lots of reasons that I'll try to underline. And also, just to be clear, I'm not here, therefore, to talk about what might be described as the deep end of the mental health pool. There still is one. It still faces lots of challenges. We're still going to need it. And if you've got a couple hours, you can talk to me about that. So this is all about focusing on the challenges of bringing behavioral health into primary care. So just for starters, there are these 3 reasons why it's essential to do this. The first is most people who get any care from anybody in healthcare, including behavioral health, get it in primary care. So primary care is where people show up. I mean, there are more behavioral visits done to pediatricians than any other category of visits, except during flu week. But we're not doing that well with it right now. A second reason is cost. Disintegrated care, we talk about evidence-based care, but disintegrated care is against all the evidence. It does not work. It costs more money. Just an article in Health Affairs in November that reiterated again that depression, for example, employees who were depressed used on average 48% more health services than employees without depression. It's the #1 condition that drives excess use of health services in general. And the third reason why to do this is it's trending. This stuff is absolutely coming our way. Better to get in front of it early rather than late, even though doing it right is a challenge, and there are a few large systems that have mastered it yet. This is data from a guy at Harvard, so we know it's got to be true, that just looks at the intersection of physical and behavioral health needs. So this is the universe of people who have either a behavioral health problem, that's the blue, or a medical problem, that's the green. And what you can see is that a substantial portion of people with medical problems have mental disorders, and a majority of people with mental disorders have some associated medical condition. So just that point in and of itself makes the argument that trying to figure out how to integrate is common sense. This is a deeper view of that problem that I don't have time to get into too much, from Wayne Caton, that builds on other work done by Vince Felitti and Robert Anda, that shows that childhood risk factors drive adult chronic illness. So childhood mental health problems, if you include abuse or neglect, sexual abuse, physical abuse, et cetera, drive both mental health problems but also medical problems. And so this is an argument for the importance of this, particularly in pediatrics, where in many ways Massachusetts is well ahead of the pack, although the pack is not doing so well on this. This is just a different illustration. The primary author of this sort of stunning piece of work, the Adverse Childhood Experience Study, and there's a website here that is sort of a clunky website, but to get a synopsis of this, don't go to the website. Look at David Brooks' column in the New York Times on September 27th, what he calls the psych approach, and I'll just read one sentence out of his column. Motivation, self-control, and resilience are together as important as raw IQ and probably more malleable. So the attention to these childhood problems is part of the solution for, still unaddressed solution for school reform as well as for health. This is just one illustration out of that study. It tracks the smoking by the age of 14, first of all, on the left, and then COPD this is among adults in midlife. In relation to the ACE score is just the number of different categories of these adverse childhood experiences that people experienced. And so what you see is a logarithmic relationship, first between the ACE score and smoking, and then, a relationship between these childhood behavioral problems and COPD. So these guys say that a majority of adult chronic illness costs in the United States of America are attributable to untreated childhood behavioral problems. A lot of researchers tend to wax maybe a little too enthusiastic about their stuff, and these guys may be too enthusiastic, but even if it's not a majority, this is still a particularly big deal. This is a different illustration that just underlines something that I've said before. The circle is the universe of people who have a diagnosable mental health condition in a year. Again, this is from the update to the National Comorbidity Study led by Ron Kessler at Harvard. It's one of the sub-studies. So you have all the people who have a mental disorder in a year. The red are the people who get nada. The dark blue are the people who see somebody in the deep end of the pool, a therapist, a mental health center, a specialist in mental health care. The green are the people who go see their GP and get something. So more people are getting something for their mental health problem in the general health sector than in the whole specialty mental health sector combined, although that still lags behind the people that are getting not much of anything. And the specialty mental health sector, while it's important for those people with catastrophic mental illness and is going to remain so, it is not going to solve this problem. Now, forget about it, as they say in Brooklyn. Then this is just a cartoon that illustrates that the guy is out on the ledge and the cop is saying, we couldn't get a psychiatrist, but maybe you'd like to talk about your skin. Dr. Perry's a dermatologist, which any practicing primary care physician can tell you stories about this. This just popularizes something that everybody knows. Survey after survey says that when asked to rate the quality of care received by people referred to specialists, mental health comes in last in every single survey. The rule seems to be you can't get in for an appointment until just after the time when you're willing to go. So, we can't solve this problem in the deep end of the pool. Now, if you're going to try to solve this problem, what do you have to do? Well, we're starting in a not great place. This is more data from the National Comorbidity Study, which looks at those people who are getting something in primary care and looks at whether it's minimally adequate. Minimally adequate means the dosage of the care, like the number of sessions you get or the amount of time you spend on the SSRI, are enough based on research studies to give you like a moderate level of improvement. And basically 1 out of 8 people with depression in primary care are getting adequate care. The pattern is, consistent. I'm not feeling so well, I write you a prescription for that, you take it for a while, you feel a little better, you go off it before you've achieved full clinical benefit. So a little bit of this is just not good enough. But fortunately, we have some solutions. And so these are the following things that in and of themselves are not sufficient to solve this problem. Training of PCPs, not enough. Protocols like let's screen people, not enough. Consultation available, not enough. And the reason why all these things are problems is that this last point here, the culture eats strategy for lunch. This is a quote from Larry Green, who's a family practice doc in Colorado who's working on this issue of integration, and in working with practices trying to do this work, unless the culture of behavioral health, we do the 50-minute hour thing, meets the culture of primary care, where you've got, if you've got 15 minutes, Dr. Harris, you're doing better than most places. Unless we figure out a way to balance the amount of time that these different interventions take, it's not going to succeed. But we do have solutions, and these come together under the name of collaborative care, which just has these elements. You got to have a mental health person on the floor. On the floor. Not across town, not in a different location. They've got to be on the floor. And then you have to do these other things to wrap around them. You got to have some training. You got to figure out how to get this into the medical record, a registry or some kind of stepped care like you would for any chronic illness. You try something, you measure if it's making a difference. If it's working, fine. If it's not working, you better try something else. One try is not, it's not enough. And these methods that go into the rubric of collaborative care, there have been lots of research studies by now, over 40 of them, impact, prospect, they have all kinds of labels. This is just one illustration of what happens. And so you see at baseline, and then after 12 months, the usual care is the blue. And so what you see is these very significant difference in physical functioning as a result of treating the depression. So we know that the outcomes are available. This is unfortunately too much of a researchy thing right now than a thing that's been implemented in practice. But the research evidence is overwhelming. Over 40 randomized controlled trials at this point. They mostly focus on depression, which is the most common and disabling of mental illnesses and is usually very well treatable if you handle it right. So it's a good place to start. But it's logical that the same approaches would work for ADHD, would work for mild anxiety, and a lot of these other conditions that give people a lot of pain and get in the way of their overall medical health. There is some large-scale implementation. Kaiser has done a lot of this, group health. The Diamond Project in Minnesota, which is a collaborative among over a dozen health plans with over 80 clinics. And there is a program underway in New York State to bring this into primary care. This is a summary from a guy who works with the Preventive Services Task Force. His quote is, "Collaborative care provides a significant and substantial increase in response, taking a clinical response rate of 46 to 48% with usual treatment and increasing this by 92%. This may well represent the holy grail of healthcare delivery." So these interventions can be effective, but not by doing just a couple parts. You've really got to jump into the pool. So the point that Dr. Harris made about trying to get people to move along that three-tiered continuum in terms of behavioral health integration is very important. Lots of challenges here to work through, and I think the payment reform is going to begin to address many of those, because one of the underlying reasons is you can't get paid for the physical codes in behavioral health settings, and you can't get paid for the mental health codes in medical settings. The payment reform here is going to take a significant step in that direction. This is just a partial listing of some resources that are out there to work on this problem. This is an issue that SAMHSA and HRSA are pushing, as well as AHRQ. And one of the nicest initiatives that is not statewide, but is a collection of a dozen or so pilot programs is in Marcial's case, in Marcial's state of Colorado. All these websites are worth taking a look at. So thanks and good luck.